our evening. We have a presentation by someone that I think probably everyone, or at least the vast majority of people in the room, know. I asked Dr. McLeod whether he was a cat or a dog person. He said a dog person. Now, I said that that was not a good thing. And I'll tell you why. You see, because if you have dogs, if you're a dog person, you have to be walking the dog. You have to, if you go away, get someone to care for the dog. There's always things going on. Cats allow you to just relax because they sleep most of the time. So it's okay if you sleep most of the time. With dog people, you can't do that. And I think that when I tell you some of the things that Dr. McLeod is involved in, you'll understand why he's a dog person and not a cat person. He is chief of general internal medicine. He is a member of 12 committees. 12. Most people can't handle 2. Not only that, he has memberships in 19 professional organizations. I can't manage 2. He's also currently involved in 12 research studies. He should be a cat person because he obviously needs to learn to relax occasionally. He shouldn't have a dog because he'd never be able to have time to take the dog for a walk. But being involved in all of those research studies related to liver disorders, I'm sure that we here are lucky that we have someone involved that's on the cutting edge of what's going on with liver diseases and how best to manage PBC. So I would ask you to please join me in a warm applause for our liver doc, Dr. Magnus McLeod.
Thanks very much. The caveat is I don't own a dog, but that wasn't the question before. I'm just going to change the camera angle here. Perfect. So the other caveat is that's an old CV I gave her too, and there's a few more things that weren't included, but that's okay. I'm going to get the presentation going, so I'm just going to share my slides if I can figure it out. I don't know if I'm sharing this yet. So many screens on here. Okay, just going to ask to make sure that my slides are correct on. Perfect. Are they okay on the Facebook Live? Perfect. So I'm going to give a little summary presentation on 2 aspects of primary biliary cholangitis. I'm going to first actually talk about the fatigue that's not associated with it. And I'm going to talk about the itching that is associated with PBC. PBC has a number of symptoms that are they're not really related to the liver disease itself in a way. And I like to call them kind of extra hepatic or non-liver symptoms of PBC. And I've listed a few of them there, but as I said, I'm going to mainly talk about itching, which is what pruritus means. And I'm going to be talking about fatigue. All of these symptoms, however, cause a lot of quality of life issues. And they're, when I see patients with PBC, they're not asking me most of the time about, sometimes they do, but they're not asking me about my numbers getting worse or are my, is my jaundice getting worse. The big questions I get a lot are, I'm really itchy and, I can't, it's difficult to manage my daily job. And I'm tired. I can't really work anymore. And so these symptoms are probably the more distressing symptoms of PBC yet. They're the ones that we don't probably pay enough attention to in making medications and dealing with in clinical practice. Fatigue is the most common symptom in patients with PBC, and it affects 50 to 78% of patients. And although I say it's associated with a decreased overall survival, that's kind of controversial. It's not really associated with how bad the underlying liver disease is. And sometimes when you have a perfect liver, meaning you don't have fibrosis or scarring in the liver and you don't have an abnormal alkaline phosphatase or an abnormal liver biochemistries, the fatigue can be worse than someone who has end-stage liver disease and requires symptomatic treatment of their cirrhosis. But it's still quite unclear why patients with PBC who don't have scarring in their liver get fatigue, and that's still a work in progress. So when I see a patient and they have fatigue and they also have PBC, I like to ask myself a few questions first. One, I like to take PBC out of the equation and kind of treat a patient like they don't have PBC, because that's how you don't want to just pigeonhole your diagnosis to blame the PBC. So the first thing I like to ask myself, is this fatigue, is this acute, meaning has it just happened in the last few weeks? Or is it chronic? Has this been ongoing for months to years? Different acuteness of fatigue tells us different etiologies or causes of the fatigue. The next thing I like to ask myself, is this fatigue actually sleepiness? Because there's a difference between being tired and fatigued versus being sleepy and not being able to stay awake. And then I like to ask myself, is this fatigue related to the liver or is it not related to the liver? Because hepatic manifestations or liver manifestations of fatigue can be from other things. And then I always, in the back of my mind, and this isn't very common, is this fatigue related to malignancy? That just is another term for cancer. So when I talk about the temporal relation to fatigue, acute versus chronic, acute fatigue, meaning this happened within the last few weeks or it started in the last few weeks, that's always an acute medical condition. And these are the patients who I work up fairly extensively, make sure there's no significant infection. Is there a new medication that's happening? Are there substance uses like opioids and that stuff? And then sometimes you have to think of heart disease, kidney disease, respiratory disease. If it's chronic, that's kind of when I go on to the sleepiness question. Could this be more sleep related? And the things that I ask about fatigue when I ask patients, like, do you have trouble staying awake during the day when you had a good night's rest? And if it is sleepiness, that seems to be more prominent than the actual fatigue. I consider things like sleep apnea, which is quite common in our population in general. And I think of things like insomnia, and you have to kind of take a sleep history to figure out if insomnia is causing the fatigue. Restless leg syndrome is quite common. Restless leg syndrome can happen as well when you have significant iron deficiency as well. And then narcolepsy and hepatic encephalopathy is something that we see in patients with cirrhosis of the liver, but that can cause sleepiness problems. And then medications and substances. The liver causes of fatigue really come down to, does it have a significant amount of scarring or cirrhosis of the liver? If that's true, I worry about, as I mentioned before, hepatic encephalopathy, or that's the inability of the liver to deal with the toxins associated with the body. Or cirrhotic cardiomyopathy, all that means is the heart muscles are not contracting properly because of the underlying cirrhosis. And sometimes patients with cirrhosis get adrenal dysfunction. And the adrenal glands are those glands that are above your kidneys that produce the stress hormones of the body. And those stress hormones are what kind of keep you awake. And when I think of patients with PBC, you don't have to just have PBC. There's other causes of liver disease that can happen in addition to the PBC. Some patients with PBC do drink alcohol, and you can get alcohol-related liver disease on top of the PBC. Some patients have viral hepatitis, which you have to make sure you exclude. And then you can have other autoimmune diseases that affect the liver that can be associated with PBC, such as autoimmune hepatitis, as I have written there, AIH. You can have non-alcoholic fatty liver disease, and you can have primary sclerosing cholangitis also involved. All of these things cause fatigue, so it's good to make sure you know about this stuff. And then you have a big list of other things that can cause fatigue. It's not an easy thing to figure out in general, but some of the more common things I think of are listed here. And in brackets, I have the test I usually do to make sure that's not causing the problems. Depression and other mood disorders happen to patients with chronic liver diseases. And in PBC, I know Mark Swain has shown that mood disorders happen more commonly in patients with PBC. The PHQ-2 is a questionnaire that kind of is a screening tool we use for depression. But there's common questions that we use in our medical practice every day that kind of can screen in or out depression. Thyroid disease, it was on our quiz today. Thyroid disease is probably one of the most common causes of fatigue and is probably the most common autoimmune disease associated with PBC. Celiac disease has an easy blood test, and I usually check it every year in patients I follow with PBC. And vitamin D deficiency, a very common cause of fatigue, and a very easy treatment to fix it. Anemia, a lot of patients with PBC have causes for blood loss. I won't get into it, but on a lot of patients with cirrhosis or advanced fibrosis or scarring can have other reasons for blood loss, and that leads to anemia and leads to quite significant fatigue, which can be easily treated as well. Pernicious anemia, that just means vitamin B12 deficiency from an autoimmune cause. Easy blood test for that and an easy treatment. And then Addison's disease, not as easy to diagnose, but something you have to think about because it's an autoimmune disease. And that's another adrenal insufficiency problem. The adrenal glands can come into play again. And then other rheumatologic diseases can cause fatigue. There's a number of medications that we as physicians don't really think of as causing fatigue, and sometimes we hand them out like candy. Not so much cannabis or alcohol, but cannabis is handed out like candy more so nowadays. But that can cause significant fatigue. Obeticholic acid has been associated with fatigue, albeit rarely. And then diphenhydramine and loperamide, which is a treatment for diarrhea. And then beta blockers, which a lot of patients are on when they have cirrhosis of the liver, can increase the chances of fatigue. So this is my thing I quickly fixed before this presentation. The arrows aren't as perfect as I had them before, but it doesn't matter. So this is just my approach to a patient with fatigue. And this isn't my approach to patients with PBC and fatigue. This is my approach to all patients with fatigue. And it might have more liver-related things than another doctor who might look for causes of fatigue, but I go through the sleepiness. First, you have to figure out if it's acute, and if it's chronic, ask about sleepiness. If it's related to sleepiness, I go through my little algorithm that I taught you. And if it's related to liver diseases, you can do liver tests. You can see if there's cirrhosis. We have good tests for that. Viral hepatitis is easy to look at. We have a lot of blood work that we can rule out many of these different things. Depression is just a screening test. Medications are easy to look at. You just ask the patient. And then an initial workup I have there is usually the workup that is done routinely in most patients and most patients seen by physicians. So that's kind of my quick run through of what I think of when I see fatigue. There are many causes of fatigue, but unfortunately, many patients with PBC don't have one of these causes. And then at this point, when I go through all of this, if a patient has none of these positive, I blame the PBC. Things that I do like to do when there is a mood disorder, I do have certain medications that I do like per se. Bupropion is an antidepressant that if a patient has a mood disorder, or if they have an alcohol use disorder, or if they have a smoking disorder, bupropion can help with all of those things in a way. And so I like to use it in patients who don't have significant anxiety because it can be it can rev you up a little bit. So I think Mark Swain and I can't remember which conference it was, but there is a bit of data that bupropion can help with fatigue related to PBC. And so it's one of my antidepressants that I'll suggest in certain patient populations. Sertraline is an antidepressant that is used for itching. And so sometimes if a patient has significant itching or has significant insomnia, I consider that because sertraline can make you tired at nighttime. Mirtazapine is a medication for depression and anxiety. It has been shown to have improved outcome, it improves outcomes in patients with PBC. And so I do consider it in patients with PBC and mood disorders. The caveat being it can cause drowsiness, which can be bad. But it can also cause weight gain and increased appetite, which can be bad if someone has associated non-alcoholic fatty liver disease. In regards to malignancy or cancer, I have a few things I think about. If a patient has fatigue and it's associated with intermittent fevers that have been ongoing for quite some time, if they have drenching night sweats where they wake up and the bed is wet and they have to change the sheets, or if they have weight loss that just can't be explained very well, I do consider cancer. And there's no real cancer that's more common in patients with purely PBC, but there can be associated conditions that can increase the risk of certain cancers. It's very important if someone has fatigue to get their normal screening or cancer screening, breast cancer screening, colon cancer screening, and we all have those. Lung cancer screening is very important in patients who have smoked for a significant amount of years. And then liver cancer patients need to have or liver cirrhosis patients need to have their liver cancer screening as well. So that's all I'm going to chat about with fatigue. And I'm going to move on to the second most common symptom in patients with PBC. And this was a diagram that I like to use because I feel like it maybe shows a descriptive image of what it feels like. Doesn't really fit the demographics of most patients with PBC, but that's okay. So early studies did report that itching was seen in anywhere from 20 to 70% of patients with PBC. Maybe a little bit less common now, but that's quite a wide percentage range anyway. We may be diagnosing PBC a bit earlier these days, but I would maybe argue against that. Itching in PBC can be either local, meaning it affects just one spot of the body, but more commonly it's pretty diffuse, mainly affecting the palms and the soles of the hands. And it's that type of itch that is so deep that you can't really get to. It's exacerbated to an extent by certain clothes, heat, or pregnancy. Can be exacerbated by other causes of itching, like having dry skin, or if you're taking too hot of showers. And it's not really associated with the severity of the underlying liver disease, but it can even get a little bit better as you get more severe. But I wouldn't say that if your itching gets better, that your disease is for sure getting worse. So don't worry if you're not all itching right now. Chronic itch can be caused by a number of things. And so like fatigue, when I have someone complaining about itching, I don't automatically just assume it's their liver causing it. And so I do think a bit. It's very important as a specialist to not kind of, just do algorithms and not think about what you're doing, because every patient's different, every presentation's different. But this is my algorithm that I think of when I see patients. So if the itching is mainly related to a skin disorder, meaning there's a rash and the itching is caused by that rash, that's definitely not related to PBC. PBC doesn't cause a rash. However, when you itch enough, you can cause a rash from the itching. And so it's very important to differentiate, is this itching causing the rash, or is the rash causing the itching? Which, if it happens for long enough, everybody forgets what's, the chicken or the egg thing. But there's certain types of rashes that are related to itching versus not. And I don't have pictures of them, but I have names. Prurigo nodularis and lichen simplex are chronic scratch rashes. But if there is a rash that causes the itch, I don't know how to deal with it. I send them to dermatology. But most primary care practitioners are very adept at treating rash-related illness. But if there's not affected skin, then it's something internal. And as a general internist, I have a little bit more comfortability dealing with that. So there's many systemic diseases that cause itch. Kidney disease, lung disease, they all can lead to itch. Neurologic diseases are another one, but that's the itching's up here and it's not really here. And the psychiatric disease is kind of the same thing, but different diseases. But when I've ruled most of those things out, I do blame the liver. And there's a number of treatments you can do for this. This is the, a generalized image that's everywhere that kind of practitioners use. I don't really use it. First off, the general recommendations, they're easy for us to say, but they don't really, in my opinion, they don't help too much. You can, if you really have the itch of PBC and it's bad, skin moisturizers aren't going to do anything. It might take the edge off a little bit, but keeping your fingernails short, that won't help you. That'll just make you more itchy, really. But it'll prevent those other skin rashes or itch rashes from happening. And we use antihistamines a lot, but it makes you sleep through it a little bit better. In general, though, when you have an itch, I really like to treat two birds with one stone, or not treat, or hit two birds with one stone. Sometimes I like to do three birds with one stone. So if there's a disease or an issue I can treat with the same medication, I like to do it, because why have two medications when you can use one? So for example, if someone has depression and they are itchy from PBC, I mentioned sertraline earlier. Sertraline treats both. And so even though if I go back, sertraline on this thing is one of the second line options. And actually in the guidelines, it's usually the fourth line option. I go right up front to sertraline before I use anything else, because I want to treat two conditions. And depression can cause itching. So I've never been a big fan of these, every patient uses the same treatment plan. If patients don't respond fully to ursodiol, or they don't respond to obeticholic acid, or they're on both and they haven't fully responded, I do like to use fibrate medications. And fibrate medications are, they're a little off-label in regards to the treatment of PBC, but they help in many patients with their itching as well. And so if you can help with the itching and also help with the disease itself, I do like that. And then if patients are have insomnia or fibromyalgia or have some pain issues, gabapentin is one I like to use for, or pregabalin, I like to use for itching because it can help with itch and pain and insomnia. And then there's some other caveats. Cholestyramine is used quite a lot for itch. It's the first line treatment. It's a powder that you turn into a slurry that is not, most patients don't love taking it, but it really helps a lot with the itch. But there's certain times when you want to be careful. If someone has severe constipation, and just say they have cirrhosis of the liver, and you don't want constipation when you have cirrhosis because it can lead to encephalopathy, you probably don't want to use cholestyramine first because that worsens constipation. The same with patients if you're using opioids, or you probably don't want to use naltrexone, which is another medication that's used for itch, and because naltrexone is can make you go through withdrawal of the opioids, and so you don't want to do that. And you probably want to avoid cholestyramine too, because opioids cause severe constipation. And so there's a few caveats that I like to go by. Anyway, it's just another one of those things where you can't just treat everybody the same. And we have many, the big lesson here is we have many treatments for itch, and there's more than I even listed here. There's other things we can do. I sometimes send patients to dermatologists and get the UV light therapy, and that helps. Oh, that's everything. So, yeah, so a little bit about fatigue, a little nugget about itching, and I'm happy to take any questions about this or about anything related to PBC. What do I do with this? Stop sharing. Stop sharing. Save like this. Oh, that's the Zoom.
So with the Zoom, just stop sharing the slides. It's on Zoom call.
Yeah, slides are stopped.
Okay, so I just take questions.
Okay. Yep, go
I
ahead.
have a question. I don't sleep at all. My husband can verify that, 2 to 3 hours. And daytime, I'm like the ever ready bunny. I don't stop. So that's my mystery. It's for yours to solve.
So the question was to solve a mystery. One of the folks up front doesn't sleep at all at night, but during the day is what type of bunny?
Ever ready bunny.
Ever ready bunny.
Energizer bunny.
Energizer bunny. You don't see commercials for the Energizer bunny anymore. I wonder what's going on with that. But so the good news is you still have quite a bit of energy during the day. So that's good. I don't know. All I can say is everybody's sleep cycles are different. I don't know if you've been
I
like,
used to sleep like a log. Now I don't sleep at all.
yeah. As we get older, they get a bit different too.
Oh, yeah.
I don't have an answer to that, unfortunately, but I wouldn't treat you for insomnia because it doesn't seem to be affecting your life. I'd be wary of starting medications if it's not causing you, grief or a decreased quality of life.
Well, I did have fatigue 2 years ago in February and was in the hospital for a week. So, and had low blood pressure.
Yeah, that must have been one of those causes of acute fatigue, a medical cause, I'm guessing.
Know what it was.
Yeah. Mystery not solved.
That's right. That
Yes.
doesn't help me.
No.
You're an expert, that's why I'm here. So I don't know.
If, I want to know whether it's fatigue or sleepiness. If you're not feeling tired, sitting there watching TV or reading a book, and you blink and you go to sleep.
So the question was, is this fatigue or sleepiness? If you're sitting in front of the TV, you're not tired, but you blink and you fall asleep when you're reading a book. That is sleepiness. Yeah. Yeah. Yeah.
Is it normal for people to have thoughts with PBC? If you had a chest X-ray and the chest X-ray comes back clear, are spots part of it?
You're saying spots within the lungs?
No, sorry, like marks on your skin.
Mhm. Yeah, so is this the classic liver spots that people talked about?
I don't think some spots are.
Yeah.
Some spots is that a liver spot?
So it's a hard question. So the question was, are spots on the skin related to PBC? In general, skin manifestations of PBC are quite, like, I don't know of any really. So I don't, it's unlikely related to PBC. And the other thing is, there's no such thing as liver spots. So when patients come to me and say, oh, I have these spots on my hands, which would be the most common, do I have liver disease? The answer is usually no. But then to say what the spots actually are is a bit of a more difficult question because I have to see them. Most spots, if they're smaller, those, I don't know about the big ones you were mentioning, but most small spots are more related to sun damage on the skin, especially if it's on like the dorsum or back of the hands and they're the little ones. But you can get spots from other systemic diseases. I mentioned Addison's disease, which is an adrenal insufficiency. You can get dark spots from that. But the spots are unlikely related to your liver or PBC though. Yep, question right there.
Completely different topic.
Yeah.
Way back at the start of the pandemic, I read, and I believe it was on the internet, so it must be true. There was some discussion around Ursodil possibly preventing COVID-19 or being some sort of vaccination for COVID-19. Now, I thought I read that they were doing studies on it in China or somewhere. Just wondered if you knew anything about that.
The question was, has there been any studies or any research done on, or any known results, if ursodiol or ursodeoxycholic acid, the treatment for PBC, does it prevent COVID-19 infection? And to my knowledge, I don't know anything relating COVID and ursodiol, to be honest. I haven't heard of anything, and I don't know of any studies that are ongoing. There could be studies ongoing, I just haven't heard of them. But it definitely has never been used in Canada as a preventative measure or talked about as a preventative measure or treatment.
You'll have to read more on the internet.
I think I'll have to. Yeah. Any other questions about anything? Doesn't even have to be about PBC. Any questions on Facebook?
Discoloration of stools, would you like to speak to that?
Oh, sure. In every day, I talk about stools, poop, and their color and their texture and their frequency 12, 15 times a day at least. But in regards to PBC, the stools should be normal, but when patients become jaundiced, meaning their bilirubin levels rise to a certain amount, your stools can become pale in color, and your pee can become dark in color at the same time. That high bilirubin levels can be indicative of a worse prognosis in regards to PBC. So it's something to, especially if it's not just a one-time thing, but if someone has pale stools, it'd be a good idea to get blood work done if blood work hasn't been done in some time. Okay. Any more stool questions? If not, that was very fun. I'll let you close it off.
Well, thank you very much, Dr. McLeod. We really appreciate it. And, you know, my husband, when he was in hospital, he would say, as long as you peed and pooped, they didn't care. They thought you were fine.
It's true.
But we have a little token of our appreciation.
Oh,
We
thank you very
really
much.
appreciate you coming and speaking with us this evening. And I'm sure that there will be more in the future as well. And if you ever consider leaving, no, you're not allowed to.
Yeah.
So just remember, you're here permanently to answer our questions when they come up. But thank you very much
Oh.
for your presentation today. We have to.
Get to the meeting.